Many of them, they can do it safely, provided we provide them medical advice, and advice is sought well before the Ramzan starts. Now, the decision that is it's safe to fast for individual, as we have been talking about, would start with all individuals seeking to fast should attend a pre-Ramadan sort of educational diabetes educational program with their respective physician. At this meeting, there should be a risk quantification. There should be emphasis on how to self-monitor their blood glucose and how and when to monitor, when to break fast, when to exercise, fluid meat planning. We already discussed few of these points, and medication adjustment. So at this risk stratification meeting, we have to first of all take into respect all the factors we already discussed, and ability of your patient to self-manage. Elderly, frail, poor vision, already comorbid would not be able to have a self-management, so they probably should have to be advised about the risk. Again, the comorbidities, previous experience, we covered these. And so after this initial meeting, about 4 to 6 weeks prior, we stratify these patients, whether they carry any mild or minimal risk, moderate risk, or high risk. There is for those very well, say, in terms of quantifying the risk, we can go into a little bit of more details of risk assessment. So now there are almost 12 points mentioned in this table, which include the duration and type of diabetes, previous presence of hypoglycemia, characteristics of glycemic control prior to, say, start of Ramadan, self-monitoring blood glucose possible, not possible. Are there any acute complications in recent 3 to 12 months? Are there chronic complications already present? Pregnancy, frail and someone with a impaired cognition, like an elderly person. Patient is in a laborer, say, profession, or strenuous physical exercise, right? Previous Ramadan experience. Now, if you notice, the maximum score is for the hypoglycemia awareness, that patient have been having hypoglycemia and he has not been, it is scored as 5, right? And similarly, if you look at this unstable angina, heart failure, or that's in previous last few months, it carries a risk score of 6. Now, if you take all these factors into consideration and add up score of for each of the component, you can come up with this kind of a score. If your patient has risk quantification score between 0 to 3, he is a low risk patient for any complication during Ramadan, and we'll tell the strategy. If the score is between 3.5 to 6, he has a moderate risk of developing complication, but category which falls into more than 6. So if you take for a few of the single factors like hypoglycemia awareness and maybe the active cardiac disease, make them into high risk group. So if once you have considered all these things and stratified that your patient is in which category, these are the lines to follow. So those patients who have a risk stratification score of more than 6, it's a red sign, right? So they may have one of the following. They may have severe hypoglycemia or decay or hyperosmolar coma within 3 months prior to Ramadan. They may have history of recurrent hypoglycemia or unawareness. They may be poorly controlled type 1 diabetic. They may be suffering from some acute illness in maybe respiratory infection or acute ailment. They may have pre-existing diabetes and they may be pregnant at this time, or maybe GDM, which is being treated with insulin. Chronic dialysis, CKD4/5, advanced macrovascular complication, old age with ill health, frail, and cognitive impairment, or maybe those who have epilepsy. Now, these are the individuals who should be asked not to fast at all, although many of them still would insist on, but as a physician, it is our responsibility to warn them that they carry a risk of developing complication. They should not fast. And of course, the religion also allows that sickness, you are exempted from fasting. And we can take help from religious scholars as well to convince them not to fast. Then come this moderate risk category. This moderate risk category is those who we scored between 3.5 to 6. They may be one of the following: well controlled type 1 diabetic, right? Well controlled diabetic who are on multi dose insulin injections, diabetes with sustained poor glycemic control, pregnant which are controlled on diet alone, early renal involvement in the form of CKD3 or GFR of more than say 45, 60 ml, or nephrotic syndrome, stable macrovascular complication, patients with comorbid conditions, but that does not present an additional risk. Of course, not involved in intense physical labor and treatment with drugs which do not affect coin. So these are the individuals which can be safely pulled through this fasting Ramadan period with a little bit of counseling and a little bit of readjustment of their eating pattern, schedule, and dosing medication. And then this is the third category, which is very low risk category, a low score of less than 3. Those well-controlled diabetic with A1C between 6.5 to 7.5, blood sugar fasting running between 100 to 130, blood sugar random between 140 to 80, and they are being treated on either lifestyle therapy only or maybe single agent oral hypoglycemic agents. They are on second generation sulfonylureas. First generation sulfonylureas like glibenclamide and chlorpropamide, they are this first generation with the longer duration of action and higher risk of hypoglycemia, whereas the newer agents like glyclazide or glimepiride, they are the relatively shorter acting and for less risk of developing hypoglycemia. Incretin-based therapies, those are well controlled and SGLT inhibitor on basal insulin. These are the individuals who can be safely advised to fast and complete this Ramadan fasting. Who should not fast? So I think I have made it very clear that category 1 patient with a high risk score of more than 6 should not fast. Category patient should not fast, but again, these category 2 patients can be made to fast with a little bit of adjustment of their medication and eating pattern. However, in many of the patients in category 2, as I said, the elderly who are more religiously inclined would insist on that this probably maybe their last time to say fast, and they may not live long enough to have another Ramadan. So they will emotionally blackmail you to allow you to them to fast. So this is the group where we probably have to focus our attention more. So as I said, patient should be assessed by healthcare practitioners 6 to 8 weeks before. You have to assess, take a detailed history, look at the previous experience, note down patient ability to self-manage, risk quantify, tell them how to and when to monitor their sugar, when to break fast. And after that assessment, you have 2 pathways. Either you allow them to fast because they are moderate or low risk group, and their frequency of blood sugar monitoring maybe 1 to 2 times a day, maybe at Sahar time, or maybe at around between 3 to 5 p.m., where there is possibly a risk of hypoglycemia, and maybe another after iftar as well. But those in whom you advise not to fast or moderate risk, if there is very high risk group, you should ask them not to fast. If they're a high risk group, but still they insist on fasting, then you have to have increased frequency of their blood sugar monitoring, maybe several times a day. We'll just that. Again, they should be told, this group should be explained that they should break their fast if their blood sugar at any time of the day is less than 70, and this should be rechecked after 1 hour. And if it still is, it should be the patient should break their fast. If their blood sugar goes more than 300 and they become symptomatic of hyperglycemic symptoms, increase polyuria, and there is a risk of progressing it into, say, this hyperglycemic state, of course, they should break the fast. Or any time of the day, even if blood sugar level is not, say, very low or not documented, but they have symptoms of hypoglycemia or an acute illness occurs, they should not continue their fast. The next question is that those whom you have allowed to fast, but they would ask our dining table in Ramzan is usually the time of the year when we eat a lot and we eat, say, unchecked, right? So we feel most of the time, even if those who are not even diabetic or both of them, at dessert time, we have a paratha and lassi and so many other things. And then at iftar time, it would have 4 or 5 different varieties of, say, snacks, and of course, followed by so many type of juices and sharbats and whatnot. Now, it is important that how to tell your patient what to eat, a diabetic patient. So there are 10 principles of Ramadan nutrition plan. You have to divide an adequate amount of calories between sahur, iftar, if necessary, 1 to 2 snacks. This 1 to 2 snacks mean at the time of iftar, not midday snack, because patient would be fasting. Meals should be balanced with 45 to 50% of carbohydrate, 20% protein, and 30 less than 35% fat. We have to design meals using Ramadan plate method. I'll just be elaborating on that. Avoid sugar and heavy desserts. To have to select foods with a low glycemic index, which means that after intake of say that meal, the immediate rise in blood sugar is not very high. That is a high glycemic index. But those high fiber type of carbohydrates, which would not lead on to a sudden surge or increase in blood sugar, they should possibly be preferred. We have to maintain hydration with adequate intake of water, both at Sahar as well as Iftar. To have to delay their sahur to as late as possible so that you minimize the risk of fasting period. Because sometimes some people may have the Sahar time is at around 4, they would have their meal at 2:30 or 3 and then would like to go to sleep and may have unnecessarily prolonged the duration of their fast. There should be an adequate protein and fat should be consumed at sahur to induce satiety, right? So you have to take the meals which have a more of a filling effect. And iftar should begin with water to rehydrate, and then 1 or 2 dates are allowed to raise, and maybe one simple snack or maybe small samosa or a small snack pakoda may be permitted, but not, of course, that the moderation has to be kept into mind. So low-calorie snacks such as fruits, nuts, vegetables may be consumed between the meals, I mean, after the snack. This is the concept of what we called as a showing to your patient that you may have these food items, pictures being taken and made, and this would make them that this much amount of say certain food item would give you this much say calories and this much of the fat and this, right? So it is easier to explain. These have been taken from a book, and they do mention an average size of a serving, one single serving. If you double it, of course, the number of calories and number of the say carbohydrate content and fat would be duplicated. Now, these are simple foods which can be easily made at home, and of course, they can be they are tasteful as well, and they have the required amount of calories and required amount of. So we can share some of these pictures later sometime as well. Now, after you have decided that what to eat, how much to eat, and how to say redistribute the caloric content and the fiber and fat content of your meals. Next question is that how frequently they should monitor their blood sugar. So frequency of blood sugar monitoring, as we said, those in a very low risk category, it can be maybe twice a day. at Sahar and maybe midday or maybe a third time after iftar as well, 2 hours after iftar as well. But if all individuals should break the fast, if this we already checked, the blood sugar is 70 or less, or it remains so till even 1 hour after the initial assessment, or sugar is 300, and that this is does blood checking blood glucose and injecting insulin invalidate the fast? This is a common question. Each and every person, वो जी blood sugar check करने से तो रोजा टूट जाएगा, इंसुलिन लगाने से तो रोजा टूट जाएगा. There is nothing like that. There is a fatwa from Jamia Azhar. There is fatwa from so many muftis from around the world that checking blood glucose does not break the fast, particularly when, of course, when we are commonly using this needle sticks and within. Similarly, injecting an additional dose of insulin at midday or somewhere to control hyperglycemia again does not invalidate the fast at all. So this is to clarify that sometime you may have to inject an additional dose of insulin midday. Blood sugar is running in excess of 300, and right. And similarly, you have to pricking the needle to check blood sugar. So it is of vital importance that insulin treatment is taken and blood glucose levels are monitored frequently. How frequently varies. Ideally, you may have to have like pre-Ramadan multiple checkings, right? We did classify into low risk and high risk group. The low risk group may be sufficient to have a morning sahur time or before the sari, and one at around 2 to 4 p.m. And then if at that time the blood sugar level is running low, less than 100, you have to be careful and may have to recheck after some time, and then maybe after this iftari. But otherwise, in those who are high risk patients and who insisted on, or a moderate risk patients, they may have a more frequent checking starting from a pre-dawn at Suhoor, maybe at around 11 or 10, then a midday reading, mid-afternoon. Of course, this is not practical to have 7 or 8 readings done. So you have to individualize that decision of when to check the blood sugar. Third question is that do we need to modify our patient's medication according to their needs or requirement? So we have made it a simple table. If your patient is taking metformin alone prior to Ramadan set in and is very well controlled, daily dose of metformin should remain unchanged, right? So if patient is taking the shorter acting type of metformin, or not the sustained release one, or taking once a day, it would be better to take at iftar time. And if it is taking twice a day, it is taken at both iftar and sahar time. So if patient is already on say 500 milligram of metformin 3 times a day, in that case you can take the morning dose as already being taken at sahar time, and combine the afternoon and the dinner dose into iftar dose and take it both right. Now, if your patient is on a extended release type of preparation of metformin, it should be taken at iftar time. For acarbose, you need not to change any modification. For triazolidinediones, again, no dose modification. Dose can be taken either with iftar or sahur, depending upon the previous patient routines. If patient is in short-acting insulins, secretagogues, which means the drugs like say repaglinide, or drugs like say glyclazide or glimepiride, the thrice a day dosing may be reduced and reduced doses taken. So this is particularly regarding the repaglinide or glinide type of sulfonylurea-like drugs, which usually are given, which are very short-acting in sulfonylureas, and they may be given in thrice a day dosage prior to, but during Ramadan, you switch it to twice a day dosage. Those who are on GLP-1 receptor agonist. Most of them, these are injectable form. And once prior to Ramadan, we have reached an appropriate titration. This dose can be continued during Ramadan as such. Similarly, for DPP-4 inhibitors, in most of the time, you would not require any dose modification, right? It is sulfonylureas which say need to be considered more closely, like newer sulfonylureas, glycoside and glimepiride. Preferably, you should switch them from glibenclamide or dianyl or chlorpropamide or glibanize to these two agents, which have say slightly lesser duration of action and low risk of causing hypoglycemia. If they were on once a daily dosage prior to Ramadan, you can take it at iftar, and those may be reduced in patients with good glycemic control set. If they were already on, say, 4 milligram of glimepiride, you can reduce it by 25% to 3 milligram and take that dose at iftar time. But those who are on twice a day dosage, the iftar dose remain unchanged as it is, but sahur dose may be say reduced by 25 to 30% at the sahur time. So this is regarding the sulfonylureas. For last 2 or 3 years, we are increasingly using SGLT2 inhibitors as an agent of glycemic control. They need not any dose modifications. Theoretically, there is risk of causing dehydration, but this initial glycosuria, which occurs and water deprivation, settles in after a few initial dosage, and this dehydration is not a serious problem, right? Preferably, this dose should be taken if they are taking this medication at the iftar time, right? And of course, we can guide our patients to take extra fluid to avoid any, say, dehydration, particularly when they are not fasting after Sahar or at iftar time. You should be careful to use these agents in elderly patients, because these are the ones who are at risk of both dehydration, some hyperviscosity associated with it, and of course a risk of hyponatremia, theoretical risk, and they may, and particularly in GFR is more than say 45 ml, then they should be carefully treated. Similarly, patient taking other diuretic should be considered probably to be switching on to other agents rather than putting on SGLT2 inhibitors. Insulin, again, if your patient prior to Ramadan was taking insulin, you preferably switch to insulin analogs where possible. So we have various types of insulin analog, longer acting, intermittent, and insulin. So if patient is on once a day dosage of NPH or Detimar or Glargine or Degludec, which are insulin analogs with a longer duration of action, do not have a peak effect and would not give rise to an immediate surge in insulin and a risk of hypoglycemia. So these can be continued in the same dosage, preferably at that time. And usually, since the duration time, so we probably have to reduce the dose by 15 to 13%. Suppose someone is on around 30 units, so you reduce it by 30%, maybe 22 units. Once a day dosage would be sufficient. If patient is on twice a day dosage, you take the morning dose at iftar time. So suppose your patient was taking 20 units in the morning prior to Ramadan and 10 units in the evening, you switch the 20 units dosage to iftar time, right? And reduce it by around by 50% in the Sahar time. So Sahar dose would be reduced by around maybe 6 to 8 units. Those who are on rapid or short-acting insulins or bolus insulins, you have to take normal dose at iftar. Since we will be omitting the lunchtime dose, we have to reduce the Sahar dose of shorter acting by 25 to 50%, because these are the insulin which would be immediately available, released, and would lead on to say postprandial say control and may lead on to hypoglycemia. So regarding pre-mixed insulin, if your patients were on once a day dosage, continue the same dose at iftar time. If they are taking twice a day dosage, again switch it to larger dosage at iftar time and reduce that dose by around 25 to 50% at sahar time, omit their afternoon dose and adjust the sahar dose. Again, the dose titration should be, again, patient's food intake would vary from day to day. It may require dose adjustment according to the blood sugar level. This is the guideline that if your patient was having a pre-iftar blood sugar level of less than 70, we have to reduce the basal insulin by 4 units. And if it is post-iftar reading is say less than 70, you reduce the shorter acting insulin by 4 units, because this is the one which would immediately lead on to hypoglycemia. And again, similarly, so you reduce by 4 units if your patient having pre-iftar or post-iftar. If it is more of pre-iftar, you would reduce the basal insulin. If it is post-iftar hypo, you would reduce the shorter acting one. Between this 70 to 90 milligram, you reduce by 2 units. If blood sugar remains in the range of 90 to 126 fasting, and say between 126 to 200 post meal, so in that case, and if it is between 90 fasting, you need no change at all. If it is persistently, the fasting sahur time level is about between 126 to 200, you increase by 2 units. Increase by 2 units. But if it is persistently fasting level is more than 200, you increase by 4 units. But remember that any dose change has to be made on every 3rd or 4th day, not that you daily keep on increasing dose. So once you notice this, you increase it by 4 units, right? And wait for another 3-4 days. And if still it is high, you can increase it further depending on what level as patient has achieved. So in summary, the rising prevalence of diabetes in the Muslim population, combined with the high numbers of people who want to fast, creates a pressing need for us, the healthcare professionals, for effective guidance of your patients for the management of diabetes during Ramadan. The IDF and DAR practical guidelines are available online on net. They are quite a lengthy one. So we have time. You can go through that in more details, and they would give you all the background and practical information. You have to individualize Ramadan specific treatment for each individual, depending upon, as we mentioned, their age, their type of diabetes, and presence or absence of previous comorbidities or previous experiences with hypoglycemia. You have to select patient who can safely fast, and you have to identify patient who cannot fast. You have to educate your patient. You have to communicate with them more frequently. You should be accessible for any critical changes or for the successful completion of Ramadan without any, say, peaks and troughs in the blood sugar levels. And of course, there is more research which is required for understanding and safety of diabetes in Ramadan. So with that, I finish my talk. I have been as say service to our say medical profession and colleagues, Pakistan Society of Internal Medicine, which I represent as a senior vice president. We have made a 2-page document on very brief say these guidelines that what to do, what not do, and we'll be sharing that with the help of our pharmaceutical colleagues from all the say companies, that they would be sharing these documents with our family physician, family practitioner, junior doctors as a rapid or ready access to better say manage their diabetic patient during Ramadan. Thank you. And